Thank you for watching this talk entitled Medication-Assisted Treatment and Suboxone in the Hospital Setting. I am Christopher Viscopoulos, and I am with one of my colleagues, Dr. Zuckerman, and we're going to do this talk here. This will be in two parts, and this is the first part. Here's an outline of the talk. We'll cover why of Suboxone and the current opioid epidemic, prior prescription patterns, dependence, tolerance, and addiction, Divergence, genetic component of addiction to opioids, the pharmacology of Suboxone and naloxone, patient selection with initial labs, induction using the COWS metric, in-office or home, SHOUT program, maintenance, which is follow-up labs, understanding that this is lifelong treatment, and then what if there's failure and we'll introduce other options. So this first slide here introduces us to why are we here? And any of us that are practicing medicine right now in our current era know that the level of prescription opioids has increased dramatically. And this slide here starts in 1999, and then we see it here ending in 2010, and we see the top slide here, the top bar here showing sales of prescription opioids. Unfortunately, deaths correlate with this as well. And this has led to part of the reason why we're having this talk now, because of opioid complications and death. This here shows where the U.S. is in relationship to the rest of the world. And here we see the U.S. all the way here on the left. And we see that we, by far and away, prescribe the most opioids. Canada is second, probably only because it's so close to the United States and being influenced. But when you get into some of the European countries, they're maybe 25% of what our prescription crisis is in the U.S. So here's a bit of a history here. So this is in the late 1980s and 1990s, a more aggressive prescription era arose. So what do we see? We had three main papers came out that appeared in the literature that changed the perception of opioid prescribing back then. So one of the papers was of 11,882 hospitalized patients with a negative substance abuse history who received greater than or equal to one opioid dose, only 4 patients developed addiction. Another one was a national survey of roughly 10,000 patients treated for burn pain. They found no cases of addiction. And the last one here that I present is 2,369 patients treated at a headache center who had access to opioid analgesics, and only 3 developed problems with their prescribed opioids. So because of this cohort of papers, this gave rise to the less than 1% message that opioids posed little risk of addiction in pain patients without a substance abuse history. This led then to, in 1997, the American Pain Society and the American Academy of Pain Medicine published a consensus statement that long-term opioid analgesic use for chronic non-cancer pain posed minimal risk of overdose or addiction. So also then in the late 1980s, 1990s, a more aggressive prescription era arose, continued here. What we saw then is in 1988, the Federation of State Medical Boards released a policy explicitly reassuring physicians they would not face regulatory action for prescribing even large amounts of opioids, assuming it was medically warranted. In 1997, Congress passed a bill, SB 402, known as the Pain Patients Bill of Rights. In 2001, the Joint Commission issued new standards requiring hospitals to make pain assessment routine and pain treatment a priority. This ultimately led to the introduction of pain assessment becoming the quote-unquote 5th vital sign. Then the movement for a more aggressive pain treatment accumulated in 2000 when Congress proclaimed the decade between 2000 and 2010 as the decade of pain control and research. Family practice physicians became the largest group of OxyContin prescribers, accounting for 21% of prescriptions in 2000 and close to 50% in 2003. So by now, I think the audience knows where we're going with this, right? In 2007, the pharmaceutical industry paid $634 million in fines following guilty pleas from 3 of its executives for criminal charges for promoting false claims that OxyContin was less addictive and less subject to abuse and diversion than other opioids. These escalating rates of OxyContin prescribing and misuse were integral to the growing nationwide problem of prescription opioid abuse, diversion, addiction, and overdose. By 2004, OxyContin became the most prevalent prescription opioid based in the U.S. The extent of the opioid analgesic use in the U.S. today is unprecedented in the country's history and is unparalleled anywhere in the world, as I showed on a prior slide. As of 2013, 1 in 25 adults in the U.S. is prescribed an opioid for chronic pain. This all led to where we're now, a backlash from regulatory and law enforcement agencies. So much so now this is from a webpage here showing in summer 2018 that there is up to 600, actually over 600 lawsuits against opioid companies, and now they've coalesced into one large federal court case. States are now suing drug companies because they don't have the resources to treat their populations for addicted patients, and they're seeking compensation from pharmaceutical companies for this. So this is where we're now. So really, let's bridge over into why of Suboxone and maybe a little bit in terms of opioid management. So some members of the audience might be familiar with the concept that we try to limit people's morphine equivalents when someone is on chronic opioids to approximately 90 morphine equivalents a day. And for those of you that might not know where that came from, it comes from this particular paper down here, where we see as if when you start getting to around that 90 number here, the rates of overdose, hospitalization, just complications in general start to go up. And then likewise here, you can see that the rates of death also go up too when you start to get to an inflection point around 90 morphine equivalent. So this is where this comes from. So this is important to kind of maybe make all of us that treat chronic pain patients a little humble. This was a paper here that looked at opioid prescribing after non-fatal overdose and association with repeated overdose. So what this was a retrospective cohort study of almost 3,000 patients. And they showed here that 1 week before the overdose, their morphine equivalent dose had increased. And then 91% received one or more opioid prescription after their overdose. So it was showing just a recalcitrance to us maybe changing our patterns and just treating patients the same way even after they overdosed. I'll highlight here just the ones in yellow. 7% had repeat overdose, dose-related. 70% post-overdose prescription from the same prescriber as before the overdose. 56% received benzos prescriptions before their overdose, and 58% had benzodiazepine prescriptions after their overdose, and 59% had mental health diagnosis in the 90 days before their overdose. So just giving us some insight into prior habits that maybe we're not aware of and why we're trying to change these.
So I think it's important right now to take a break and talk a little bit about terminology here. This is important because there's a particular myth with medication-assisted therapy and Suboxone in particular, that when you use some of these medications to treat problems with opioid use disorder, that you're replacing one addiction for another. And I think it's really important to distinguish why that's a little bit different than what one might initially think. So when we think about, there's sort of three different components here that we use sort of interchangeably incorrectly. We think about addiction, and I just want to define addiction as a chronic neurobiological disease, that there are genetic, psychological, and environmental factors that contribute to it. And really, it's marked by changes in behavior. So in other words, patients exhibiting impaired control, which you might see as people not following the script for their opioid prescription, not following the directions. Compulsive use, so not being able to stop using even after bad things happen, and then continued use despite harm. And then also demonstrating craving if they haven't had the medicine in a little while. So those are some of the behaviors that actually define addiction. That's in contrast to two sort of more physical aspects of medications like opioids, which are dependence and tolerance. So dependence is a bodily adaptation to a substance. Many different substances have this, opioids, certain antidepressants, many different things. And it exhibits a withdrawal syndrome if you've been taking the medicine for a long time and then suddenly stop taking it. Tolerance is a little bit different, and that's also a bodily adaptation to a substance. And that is where you see reduced effects of the same dose of the substance over time. And so while Suboxone and other forms of medication-assisted therapy, definitely you can see elements of dependence and tolerance in patients treated with these medicines, it's not quite the same thing as an addiction, which we defined earlier as the behavioral aspect. And so I'd like to introduce a different term that's used now in the DSM-5, which is the term opioid use disorder, which is the preferred language at this time for describing patients who are struggling with opioids. And you can see here, so there's 11 different criteria. You need at least 2 in order to meet the diagnosis of OUD. And then you have different levels of OUD based on the number of criteria you meet. And you can see that roughly they kind of break down to representing the 3 different topics that we were talking about before. Addiction in those first 8 or 9, and then tolerance being, of course, that, and then withdrawal being a separate issue. So that's important to know.
So another topic here to introduce is divergence. And so this particular slide shows a paper from urine toxicology results in chronic pain patients on opioid therapy. And here this looks at almost 1 million patients. And so the statistical significance here is excellent. And we find that with urine drug testing, up to approximately 10% of patients have illicit drugs in their urine. Almost 30% of patients have non-prescribed medications. Almost 40% of patients have prescribed medication not present. 15% of patients can have drug levels lower than expected. And a little more than 25% of patients have drug levels higher than expected. So on our patients who might be on chronic opioid therapy, this is important that we have regular urine drug testing, and that's why this slide was shown. So I'm going to introduce here a little bit about the genetic component to opioid, a genetic component of addiction to opioids. And there are a few genes that we know about. So the first one here is the OPRM1 gene. This is known as the mu opioid receptor gene. And here we have a single nucleotide polymorphism. We substitute an adenine for guanine at the 118 position. And what that leads to asparagine substituting for aspartate at the 40 position here. And what this particular substitution, which happens in the extracellular domain, does is you have an increased binding for beta endorphin, and you have an increased risk for opioid use disorder, increased use actually for alcohol use disorder, and a decreased analgesic response. And maybe some of us might be able to relate to this by, say, myself. I've been to the dentist before. I had tooth work done, and I was prescribed an opioid. And when I got that opioid, I had absolutely no euphoric effect whatsoever from the medication. However, we hear that for individuals that might possibly have this genetic mutation, when they take that opioid, they have a much different response that we'll talk about. Another popular genetic component here is the CYP2D6. This is either upregulated or downregulated in certain individuals. And so many opioids that we take need to be converted to active form. So codeine, for instance, to morphine, hydrocodone to hydromorphone, oxycodone to oxymorphone. And you need this particular enzyme intact to be able to do that. Some people are under metabolizers, and some people barely metabolize whatsoever. So here I'm showing that for in the Asian population, for example, they have much lower rates of metabolism of this drug, and they don't have good pain control if you give them a medication that needs to be converted into an active form. For methadone in the liver, it's broken down by CYP3A4, 2D6, and 2B6. There are many drugs that might increase or decrease these enzymes, and that's important to know because then that can affect the metabolism of methadone. And the last one here is the COMP enzyme. So the most widely studied variant is the 158 MET, where a guanine is changed to adenine nucleotide substitution at codon 158, which results in an amino acid change from valine to methionine. Patients with the MET-MET genotype have lower morphine requirements than those with VAL-VAL expression. Maybe in anesthesia population, we commonly think of redheads or individuals with red hair, they require higher dosages of local anesthetic. So a similar thing here for people with their opioid tolerance. So what becomes difficult with maybe along the lines of a genetic component to addiction to opioids is that pain and addiction has no objective measurement. So we can't simply take someone's blood pressure and get a number. We can't check someone's blood glucose and get a number for this. And so we have to develop other methods of diagnosing individuals and feeling comfortable with other measures to assess them. And so to this line here, continuing with some of the neurobiology and genetic components, we'll talk about just certain areas of the brain. And so here in the green, here's the nucleus accumbens. This is the limbic area. And this is being depicted here to show that this is the area that subserves individuals' response to reward in reference to opioids. The periaqueductal ductal gray area is someone's response to pain. This is our pain control area. And this right here in the locus coeruleus areas down here, this is the main area of noradrenergic response. And so this area down here is important because when someone is taking long-term opioids and they go into withdrawal, this is the area that becomes hyper-excited. And now possibly we can use things like alpha-2 agonists, Precedex, Clonidine, 10X, to inhibit people's withdrawal response. So again, the nucleus accumbens area here, it responds to euphoria and reward, pain control, and then here our main area of noradrenergic response, which we mostly see in withdrawal. So what is it like when someone who might have some of these genetic changes here, when they have their first response to having an opioid? What do they possibly say? And so common things, if patients are asked, they might say things like, all my problems disappeared, or I felt like I was under a warm blanket. I thought this was how normal people feel. They, quote unquote, forgot about all the abuse. They felt like the world was at peace. They felt totally relaxed, not shy. They felt as if they were looking at a beautiful sunset. They felt energized. And so this is that vulnerability of, quote unquote, liking opioids. This was the difference between maybe when someone like myself, had opioids with a dental procedure and someone who might have some of these genetic mutations. So I introduced this here, and this is a complicated slide, but I don't mean it to be. This is actually a cross-section of a rat brain. And the reason why I show this here is I'd like you to think about the endogenous opioid system, just like we would think of maybe depression. It's very interesting that for individuals we now recognize with depression, they might have a deficiency of serotonin, or they might have a deficiency of norepinephrine, and we need to give them certain medications to get those drug levels back up to normal. Well, there's not much of a difference here for individuals who lack the ability to regulate their endogenous opioid system. And so here what we're introducing when we get to Suboxone in particular is converting people over in a way that they could better regulate their endogenous opioid system, and they have that normal feeling within themselves that they should have without having to resort to illicit drug abuse. No different really than depression here as the example. So along this line, when we talk about the brain and maybe that analogy with depression or so, we talk about a hedonic tone in people's brain. And so that hedonic tone that we have in our limbic system, it gives us a sense of well-being, a sense of happiness, pleasure, contentment. It's set by the mesolimbic dopaminergic circuitry. It's that combination there of pleasure, reward, survival center. And within all of us, it can range from euphoria to dysphoria. And it's altered by psychoactive agents and activities. And I'll give one example of that shortly. And it's a delicate balance. It's a human condition. And here's where we're saying that perhaps some individuals with an abnormal tone could be more vulnerable to addiction. And that's maybe what we're doing with Suboxone. We're replacing that, and they have that normal hedonic tone in their brain. So let's go through one example here. So in this particular example, I show two things. I show a carrot and I show an ice cream sundae. So try to forget about the ice cream sundae for a second and just visualize the carrot. Picture eating the carrot, etc. Not many feelings, if any at all, come about in reference to you visualizing eating the carrot. There's really no emotion there whatsoever. I certainly don't feel any emotion whatsoever when I think about it. However, when you think about the ice cream sundae, for most of us, even if we're full, even if we couldn't have one more bite of dinner, if we put the ice cream sundae in front of us, we could somehow create space within our stomach for that ice cream sundae and have more. Why? Because that's associated with a certain feeling that we get. So that's in relationship to that sense of hedonic tone that we can get through psychoactive activities or substances. So in reference to this, we're going to look here at opioids within the brain and exactly where they work and how they might be influenced here in opioid misuse disorder. And so here's our ventral tegmental area and our nucleus accumbens. And I'll bring your attention here down to this first particular box down here. And what this is showing here is that normally we have a GABA interneuron that's inhibitory. And GABA normally acts here and prevents some of the release of dopamine out. So here what's shown is heroin, but it could be any opioid. Heroin's just one different type of opioid. And when that binds here to the opioid receptor, you inhibit this GABA response. And when you inhibit an inhibitor, you get an excitatory response. And so that's how some individuals, even though when we give opioids to many individuals, they get a sedative response. In individuals who might have the predilection towards opioid misuse disorder, they have that excitatory feeling. And the other area here is the more common one that maybe we think of, which is just simply when heroin or any opioid interacts with the opioid receptor, you have the normal second messenger pathway that happens here in the nucleus accumbens area.
Okay, so sort of moving our focus away from opioid addiction to talk a little bit more about Suboxone. We're going to talk about a few really important pharmacologic characteristics of both buprenorphine and of naloxone, which are the two components that make up Suboxone. Subutex is the other common formulation that we know about, and that is just buprenorphine solely. We'll talk about that a little bit too. So focusing first on buprenorphine, buprenorphine is what we call a partial mu agonist. That means that it works at the same receptors that Dr. Voskopoulos was discussing, the mu receptors, and they stimulate the mu receptors, but in a partial way, not as strongly as a full agonist, something like heroin or methadone would stimulate at those receptors. And importantly, it has a ceiling effect. So if you keep taking buprenorphine in higher and higher and higher doses, it's not going to keep exciting those pathways past a certain point. It's interesting, buprenorphine also has a very high affinity for these receptors. So although it doesn't work as strongly at them, it has the potential for kicking off full agonists that have less affinity for these receptors, things like heroin. This results in the condition that we know of as that we call precipitative withdrawal. And that's where you can go from having this very full effect at these mu receptors to a much weaker effect when buprenorphine replaces it. And that's why it's very important for patients who are going through an induction on Suboxone to be able to be in withdrawal the time that Suboxone is first administered. Also relevant to this is that it prevents agonists from rebinding, so the heroin that may be in somebody's body is not going to go back onto that. And it has a long dissociation time. And so these are the properties that help Suboxone to prevent somebody from getting a euphoric effect should they take heroin or another full agonist while on Suboxone, while the Suboxone is still working. The final thing to know about the pharmacology of buprenorphine is that it has very poor oral bioavailability. When you actually swallow the buprenorphine or Suboxone pill, only about 30% is absorbed in the stomach. That's why we administer it as a sublingual medication, meaning that it has to be absorbed under the tongue. And with that type of dosing, it has more like a 70% bioavailability, so almost twice the dose available. So very important that patients are taking that properly. The other component of our combined product is naloxone. Naloxone is a mu antagonist, and so it binds those same receptors as heroin or buprenorphine, but it blocks the effects of the downstream reactions. The goal of naloxone being part of the Suboxone formulation is to prevent diversion. And we'll talk a little bit about that, how that happens. So, of course, the combination tablet that we're referring to is commonly known as Suboxone. Naloxone has poor sublingual bioavailability. And remember, we dose these medications SL because that's how the buprenorphine is absorbed best. However, obviously it's going to have a much higher concentration if the medication is injected. And so that's how the misuse prevention aspect happens with naloxone in the medication. So in other words, if it's taken properly, sublingually, naloxone is not going to be available in the body. However, if the medication is injected, then the idea goes that naloxone would block the buprenorphine or, in theory, heroin from binding to the receptors. Important to know, though, that naloxone is teratogenic on fetuses. And so for pregnant women that you may be treating, it's important to use the buprenorphine-only medication called Subutex. This is still being studied, but it's not concerning enough that buprenorphine only is considered a safer agent.
So many of us who might treat patients with Suboxone might have heard that common dosages are around 16 milligrams, and maybe max dosages are around 24. You might be wondering where some of that information came from. Well, this is one of two papers where this came from. This was looking at functional MRI imaging, and it showed here that when you got up to a dose of 16 milligrams, basically all of the mu opioid receptors had already been occupied, and there was no more potential binding. So because of this, this gave rise to maybe a dose around 16 should be adequate to bind all of someone's receptors. But we do allow patients to go up to 24 or so because there could be some receptors that might still require to be blocked, and some patients could do better. But this is where that information came from.
We want to take a break here, and then we'll come back and we'll chat a little bit more about some of the more practical aspects of Suboxone induction.